I thank you very much for the opportunity to participate in this stimulating panel about a topic that is very timely and important. I also wanted to thank Claire Jamaria for her assistance, and as we were developing my brief introductory comments, she sent me the following 6 questions to be dealt with in 15 or 20 minutes. The prevalence of pain in the U.S. population, trends in the past 5 to 10 years, subpopulations that would especially benefit from topical products, a perspective on patient preferences, safety and effectiveness, and specific recommendations. I also took the liberty of scanning online and looking at the FDA website and understand this is a very active time. There have been guidances or similar regulatory documents appearing even this very month in the topic. We live in a world...
Could you bring your microphone? Thank you.
We live in a world where we are surrounded by various types of creams that are marketed through various regulatory procedures. This came from this month's AARP magazine and sought out people with sciatica, back or leg pain, and quoted the patient or former patient who said, "I am no longer the screaming lady. My legs are not in pain. I would not know what to do without leg and back pain relief cream." You can find similar testimonials of amazing cases actually throughout history. There's a whole history of multi-component topical potions, if you will, that got mixed together. Most recently, I have to commend the Institute of Medicine, or now the National Academy of Medicine, for its work in making pain a public health issue. I will simply refer the questions about prevalence and the importance of high impact versus other types of pain, not simply to this groundbreaking publication, but also subsequent publications that have followed. Amongst those publications was a consensus study report, now from National Academy of Medicine, on pain management in the midst of an opioid epidemic. And I don't have to remind everybody that this is a dominant public health theme. On the other hand, in considering the background for your deliberations, the committee should understand that a relevant graph is not simply the graph that shows increasing mortality paralleling increasing prescriptions for opioid pain medications. This particular graph comes from a study by Jalal and colleagues in Science a year ago and looks at individual sub-epidemics that have appeared and surfaced over the last 20 or 30 years and then subsided and run their course. The intriguing thing is on the right-hand side that if you sum the mortality from all the sub-epidemics, there's an extremely suggestive and statistically significant exponential rise in mortality rate as the sum of separate individual submortality rates over the years. This observation echoes a publication from 3 years ago by Case and Deaton, the Nobel laureate, that described the opioid epidemic as an epidemic of despair. I was also charged with talking about the evidence. Now, we're all familiar with evidence pyramids, and this was about the simplest one I could now find. They've become quite complicated. On the other hand, I would say, to set the stage, this has been a conventional way of looking at evidence in relation to medicine. That is to say, randomized controlled trials are superior to case reports, and systematic reviews and meta-analyses of RCTs are superior. On the other hand, as I'll get back to later, we are right now in a clash or controversy between trying to balance the important trend of personalized or individualized medicine with population health measures such as meta-analyses that were designed to help estimate the resource needs of entire populations, specifically in post-war Great Britain. So, what do we know? I've summarized on a single page what could be the subject of a week-long conference. But there actually is evidence with control groups, hence my use of the word efficacy, for topical analgesics. These are in daily use, and they are also, for some of them, namely the local anesthetics, used to provide anesthesia for treatment of abrasions or suturing of dermal cuts and and such. So we've actually published a couple of those in Cochrane collaboration. There is also some evidence, and it gets increasingly, with the complexity of the combination, it gets to be more of a case report level evidence on other things. So there is not a dearth of agents. Rather, the question is how to organize this into a larger structure. We understand that individual responses vary, and we need to know what to do with the striking case report. And there are case reports that are really impossible to view as simple instances of placebo, and I'll share with you one of those at the very end. So one of the other things that I noticed in the recently published and much discussed comparison of topical agents for nociceptive neuropathic pain, that is nociceptive or neuropathic pain, in a veterans group, with the senior author being Steve Cohen from Hopkins, is that the placebo arm had a very large response, and there was no separation of either of the two topical creams for nociceptive or neuropathic pain, respectively, and placebo. I believe that if one conducts studies in emergency department settings or where there's been an acute injury, there's also, we understand, a mobilization of the body's endogenous opioid system. And so the placebo responses, the effect size for placebo, may be very large. So I think we need to focus upon the aspect of study design such that if there is a very large effect size for placebo, we may not necessarily weight that study terribly negatively. There's also the issue of counterstimulation, that is to say, rubbing the cream on, which has been a long recognized confounding issue. So it is possible we may consider relaxing prevailing p-value views for efficacy indication and maybe emphasize safety more. As a matter of fact, there is going on right now what I'd call a crisis in the use of p-values and even how to frame questions of causality. The popularizer of the randomized control trial, Archie Cochrane, after whom the Cochrane collaboration was named, while he respected and thought that as he's quoted here, the RCT is a very beautiful technique, but he himself recognized snags, subgroups, and so on. So it would be a mistake to view Cochrane's contribution as saying that all medical decisions must be made through randomized control trials. He didn't say that. It was a very helpful technique to help him and colleagues in post-World War II Great Britain estimate the population health needs for the National Health Service. At Tufts, we were fortunate for a number of years to have Lois L be our dean of one of the graduate schools. Lou Lasagna also was one of the people who helped design the current structure of phase 1 through phase 3 trials for FDA. He knew all about randomized control trials. He advocated them in what became the current structure. But he also pointed out 40 years ago that while RCTs are of clear utility in establishing efficacy, they're remarkably artificial. He used to call them hothouse medicine because they don't resemble real life. Now, we know this, but he said it 40 years ago, because the drug is used by health professionals of all levels of expertise, populations are heterogeneous, there are other factors going on, and so on. So he felt that one really couldn't say one had a handle on what drugs were doing without a more naturalistic assessment of how they would be used in practice. So he said we must study the medicine in its natural habitat. As I've mentioned, there is a revolution going on now, in part driven by our ability technically to command and summon up huge amounts of data electronically, so-called big data. And this is just one of the examples written by my colleague at Tufts about re-examination of what does causation mean now in health informatics and data science. We are in an era now of flexibility. You might say that that pyramid, which I showed you, in some cases is being inverted in the era of personalized medicine or precision medicine. So people have commented upon this. For example, Tonelli and Schertz said that personalized medicine or precision medicine differs greatly from EBM, which seeks the best course of action based on population-based studies. We did a satellite symposium for the International Association for the Study of Pain several years ago. We called it Faces or the Crowd, and we focused on the odds, or being at odds, between evidence-based medicine and precision medicine. And many policymakers, for example, the former director of the CDC, have written on going beyond RCTs and alternative designs to accommodate our enhanced ability to capture large amounts of data and analyze them. Another contributor to this field has been John Ioannidis from Stanford, who pointed out a related crisis of non-reproducibility and the generation of hypotheses after the results are known, also p-hacking. So there are a number of factors contributing to the non-reproducibility crisis. So if we look at all of these efforts, and I've been privileged to work with wonderful colleagues, the National Pain Strategy, NIH, the Interagency Pain Research Coordinating Committee, Federal Pain Research Strategy, the HEAL Initiative, what does one take away? The study quality in terms of numbers accrued, the design heterogeneity, and duration are not on par with primary therapy trials that you would see in oncology, for instance, or large cardiovascular trials. We need to get back to the basics of the patient intervention, the control, outcome, and setting, and so on, to make more uniform the gathering of data going forward. One of the issues with topical analgesics is that the number needed to treat, which is reflective of the intrinsic efficacy, is viewed by many clinicians, including myself, as not always large. So there are challenges how to integrate an intervention that does not have an intrinsically low number needed to treat with other prevailing guidelines. On the other hand, I'm still troubled as a clinician that we don't want to throw out the baby, that is to say case-level benefit, with the bathwater, that is reliance upon population-based statistics. So the current crisis in causality may be both a danger and an opportunity. I am fortunate to have one of our recent graduates here with us, and in her day job, she's a hospice medical director who has assembled a number of cases. This one is a 98-year-old female with recurrent vulvar cancer, metastases externally to the rectum and internally to bowel. Prior treatment involving most of the modalities that we have in our guidelines at our disposal: neurolytic block, tramadol, hydrocodone, acetaminophen, benzocaine gel. Her pain was so poorly controlled that she attempted suicide. She was started on a cream, ketamine 10%, clonidine 0.2 milligram, that's 0.2 per ml, all of these are per ml, gabapentin, applied topically. Her pain declined to a 2 out of 10, but she was getting breakthrough pain at 2 or 3 hours. And so she had this cream modified. It was in its final form ketamine, clonidine, gabapentin, small amount of methadone, and bupivacaine. The vulvar pain remained mild through the remainder of her life, and she was able to lie down, sit up, have perineal care without pain. So I thank you for thinking about and coming together in this somewhat whirlwind introductory overview, and I look forward to the other speakers. Thank you.